So let's look at the clinical data and the science around iovera. So this was a randomized RCT looking at the impact of iovera specifically on knee OA. And this is a study that actually got the FDA approval for iovera to officially be used for knee OA. So the on-label indication for iovera is specifically sensory nerves, peripheral sensory nerves as the potential target. But this paper right here actually allowed for iovera to specifically say it is useful for knee OA. So this was a randomized controlled trial, 17 sites. You can see 180 subjects, randomized 2-to-1. And we followed the patients out at 30, 60, 90 days. And then we followed them out past 90 days if they continued to have a treatment effect. But really, the primary outcome was at 90 days. And the important point here is we set the MCID, MCII threshold. So remember, as we start moving kind of into this value-based world away from fee-for-service, we want to know, is something not only statistically significant, but is it clinically relevant as well? Right? Because let's say I come up with a new pain drug or a new medication, and I have the world's biggest clinical trial, right? 10,000 patients in each arm. I've got the sham group or the control group, placebo group, plus my new pain medication. And let's say my pain medication reduces your pain score from a score of 9.5 to 9, right? It's statistically significant because we're powered. We've got 10,000 patients in each arm. But the question is it clinically relevant? Can anyone tell the difference of your pain dropping from a score of 9.5 to 9, right? So we're starting to embrace this concept of minimal clinical important difference or improvement to try to drive home this concept of something that's clinically relevant. And so in the context of knee OA and a lot of other outcomes, we've pegged that threshold to be about 20 to 30%. So we want to see about 20 to 30% improvement in that outcome before we say it's clinically relevant. So for this study, not only did we set the threshold to be statistically significant, as we would expect it to be, but also the results had to be clinically relevant for that data to be included. So you had to have a minimum of 20 to 30% improvement in your pain and function scores for that data to be included. So if we include those patients that had that met the MCID, MCII threshold, and then follow them out to 90 days. The sham group versus the control group. The control group, when I say sham or control, it's really a sham. So we actually numbed up the skin, we inserted the needles, targeted the ISN, hit the button, the lights went off, made all the sounds, but no cold was deployed. So it's about as blinded as you possibly could be. And that really defined what the control group was. So if we look at the results of this knee OA study, so again, control group versus iovera group, you can see a significant, both statistically significant and clinically relevant improvement in the patient's pain and function scores out to 90 days. And you can see still a significant number of patients getting improvement with iovera well beyond 3 months as well. The most common side effects were bruising, numbness, redness, and tenderness. As you would expect, if you're going to poke the skin multiple times in a given area, that's essentially what you would want to see.